Hello friends, I am Dr. Vaibhav Tyagi. Today I will be discussing ophthalmology part of grand test number 180. So let's begin with question number 240 first. Tear film is not seen in. First option is chronic conjunctivitis, chronic uveitis, keratoconjunctivitis sicca, and last option they have given is herpes keratitis. So the correct option is keratoconjunctivitis sicca. Answer is KCS. So let's discuss what is keratoconjunctivitis sicca. What is keratoconjunctivitis sicca? So KCS is nothing but it is any eye with some degree of dryness is known as keratoconjunctivitis sicca. It is associated with aqueous tear deficiency. You should keep in mind that it is associated with aqueous tear deficiency. So it is KCS is any eye with some degree of dryness, right, and it is associated with aqueous tear. So to go further we should know what is aqueous, where does this aqueous comes from. So you should know the layers of tear film, right. So keep in mind the layers of tear film. So as you all know there are three layers of tear film. The first and the outermost one is the lipid layer. Outermost layer is the lipid layer, the middle layer is the aqueous layer, and the innermost layer is the mucin layer. Mnemonic is LAM. Outermost is lipid layer and the innermost layer is the mucin layer, and the middle one is the aqueous layer. This is the thickest layer of the tear film. Second layer is aqueous layer. So KCS is associated with aqueous layer, and the third layer is the mucin layer. Lipid one is the outermost and it is in direct contact with the ambient air, whereas this mucin layer is direct contact with the cornea, it is the innermost layer. So after discussing the layers of tear film, let us discuss other terms in dry eye. Dry eye. So when does dry eye occurs? Dry eye occurs when there is any inadequate tear volume or there is inadequate tear function, it will lead to unstable tear film or ocular surface disease. So it occurs due to inadequate tear volume or tear functions. Both these conditions or either of them will lead to unstable tear film. It will lead to unstable tear film or ocular surface disease. It can lead to ocular surface disease, right. It is a very common condition, please note down, it is a very common condition and it is very commonly seen in postmenopausal women. It is very commonly seen in postmenopausal women and elderly patients. Postmenopausal women and elderly patients very commonly seen. So let us discuss other terms which are used in dry eye. So what is, first term is xerophthalmia. What is xerophthalmia? It is dry eye associated with vitamin A deficiency. Dry eye associated with vitamin A deficiency will lead to xerophthalmia. What is xerosis? Xerosis is nothing but it is severe conjunctival, it is severe ocular dryness, severe form of dryness associated with cicatrization and conjunctival keratinization. It is associated with cicatrization and conjunctival keratinization, right. Now after discussing xerosis, now what is Sjogren syndrome? You have heard Sjogren syndrome. I know you know what is Sjogren syndrome. It is nothing but it is an autoimmune inflammatory disease. It is an autoimmune inflammatory disease of which dry eye and dry mouth is a clinical feature, right. So now discussing about the clinical features of dry eye. So first we will be discussing the symptoms of dry eye. The patient will present to you with foreign body sensation. He will present to you with grittiness or irritation in eyes associated with photophobia. So what are the clinical features? Let's discuss the symptoms first. In symptoms, patient will have foreign body sensation, patient will have grittiness or irritation, then patient can have photophobia, right. So these are the symptoms of dry eye. Now coming to the signs, what you see in dry eye. First sign, the tear meniscus height. This is important. Tear meniscus height. The tear meniscus height is you see when you stain the cornea with fluorescent dye and you examine the cornea with cobalt blue filter. So the tear meniscus height is less than 0.5 mm in dry eye. If it is less than 0.5, diagnosis is dry eye. What is the other sign you see? There is lack of corneal and conjunctival luster. There is lack of corneal and conjunctival luster, right. Now other signs what you see is there is conjunctival hyperemia. You will see conjunctival hyperemia and there will be conjunctival keratinization, plus there will be conjunctival keratinization, right. What else you will see in the lids? There will be a frothy discharge at the lid margin, you will see frothy discharge. So frothy discharge is seen at the lid margins in dry eye. What you see in cornea, this is important. When you again stain the cornea with fluorescent dye and examine the cornea on slit lamp under cobalt blue filter, you will see multiple punctate epithelial erosions. Punctate epithelial erosions will be seen in dry eye. So these are the symptoms and signs of dry eye you should keep in mind. Now coming to what are the tests you will perform in dry eye. What are the tests? So first and the most important one is the Schirmer's test. Schirmer's test. So students, this is a objective test. This is a quantitative test. Quantitative test. So what you see in Schirmer's test, you uses a Whatman's filter paper number 41, which is a strip like, it is a strip, and you place this strip in your inferior eyelid or the inferior fornix, and you measure the amount of wetting. So number of grading is there written on the strip Wortmann's filter paper, and you measure the amount of wetting. You keep that strip for 5 minutes and readings are taken after 5 minutes. So how you perform? You use a Wortmann's filter paper. Number 41 is used. It is a 5 millimeter wide and 35 millimeter long strip, and readings are taken after 5 minutes. So students, if the reading comes to be more than 15 millimeter, if the reading is more than 15 millimeter, this is normal reading, right? And if it is less than 10 millimeter, it is indicative of dry eye, indicative of dry eye. If the amount of wetting recorded on Wortmann's filter paper is less than 10 millimeters, it is indicative of dry eye, right? So what you measure on this Schirmer strip, you check the aqueous tear production. Write down on Schirmer's strip, it is used to measure aqueous tear production. Aqueous, it is the middle layer of tear film. Now coming to second test, which is tear breakup time. Tear breakup time. Tear breakup time. So what we do in tear breakup time, again we use 2% fluorescein dye. 2% fluorescein dye is injected, it is put inside the inferior fornix, and we again examine the cornea under cobalt blue light, right. So again we use 2% fluorescein dye. So after staining the cornea, we examine under cobalt blue light and we ask the patient to blink his eyes several number of times. So what we see, but it is the tear breakup time. What is it? It is the interval between the interval between the last blink of the patient and appearance of first dry spot on the cornea. So it is the interval between last blink and appearance of first dry spot on cornea, right. If this interval comes to be less than 10 seconds, if it is less than 10 seconds, it indicates you mucin deficiency. It indicates mucin deficiency. So just keep in mind, this is important, that tear film breakup time, it assesses the mucin deficiency, whereas the Schirmer's test, it is used for aqueous tear production. So this is all about dry eye, you should keep in mind. Now coming to the next question, question number 241, identify the instrument shown in the photograph below. So this is the instrument they have given. Correct answer of this question is answer number B, Synoptophore. So this is a Synoptophore, right. So let us discuss what is Synoptophore. Synoptophore. So guys, Synoptophore, it is an instrument, write down, it is an instrument which is used for overcoming, it is an instrument which is used for overcoming or compensating, write down, it is used for compensating the angle of squint. So, synoptophore is an instrument which is used for compensating the angle of squint, and it allows the stimuli to be projected in the two eyes simultaneously. So, it compensates the angle of squint, and it allows the stimuli to present on two eyes simultaneously, right. So, a 6.5 diopter lens is used in both the eyepiece of synoptophore, which sets the testing distance at 6 meters. Now, coming to the uses of synoptophore, what are the uses? What are the uses of synoptophore? So, it is used to investigate, synoptophore is used to investigate the potential, it is used to investigate the potential for binocular single vision. Binocular single vision, it assesses the potential of the eye for binocular single vision in presence of manifest squint. In presence of manifest squint, it is used for assessing the potential for binocular single vision. Second use, it is used to detect suppression and abnormal retinal correspondence. Abnormal retinal correspondence. So, it is used to detect abnormal retinal correspondence and suppression, right. Third use, it is also used to measure, horizontal, vertical and torsional misalignments simultaneously. So, it is used to measure horizontal, vertical and torsional misalignments of the eye simultaneously, right. So, this is about synoptophore, you should keep in mind. Other options they have given is the indirect ophthalmoscopy. Indirect ophthalmoscopy is used to examine the fundus or the posterior segment of eye, and what type of image is formed in indirect ophthalmoscopy? Real and inverted image, which is 3 to 5 times magnified, right. Other instrument they have given apart from indirect ophthalmoscopy is, so they have asked about slit lamp biomicroscopy. What is slit lamp biomicroscopy? So, slit lamp biomicroscopy gives you a stereoscopic view of external adnexa of the eye. And what are the uses of slit lamp biomicroscopy? It is used for anterior segment evaluation. It is used for anterior segment evaluation. So, what do you mean by anterior segment evaluation? Anterior segment means right from the examination of cornea, anterior chamber, then comes iris, lens and up to anterior vitreous of the eye. It constitutes anterior segment of eye. So it is used for anterior segment evaluation of eye. Then what are the other uses? You can do gonioscopy. Gonioscopy is done on slit lamp. Then you can measure intraocular pressure by Goldman applanation tonometry technique on slit lamp. Then what can be done else is, what else? Fundus examination. Fundus examination can also be done on slit lamp biomicroscopy using a plus 90 diopter lens. Then corneal staining is also done on slit lamp. So these are the uses of slit lamp, right. Now coming to the next question, commonest cause of vitreous hemorrhage in adults is, so the correct option is diabetes, option number D. So let us discuss vitreous hemorrhage briefly. Vitreous hemorrhage is nothing but it is an intraocular bleeding through which the patient will present to you with painless and sudden loss of vision, and he will complain of floaters. Floaters are nothing but these are multiple black dot like opacities. Patient complains that the patient is seeing multiple black dot like opacities. These are known as floaters, right. So write down, vitreous hemorrhage presents with painless sudden loss of vision with complaint of floaters. Now what else you should know in vitreous hemorrhage is the causes of vitreous hemorrhage. The first and the most common one is diabetes, and in diabetes also it is proliferative diabetic retinopathy. It is the most common cause of vitreous hemorrhage in adults, right. This is the most common cause of vitreous hemorrhage in adults. Now what are the other causes you should know? Second cause is retinal tear. Third cause is PVD. PVD is posterior vitreous detachment. So there is detachment of the vitreous, right. So as you all know that vitreous is present in the posterior segment of the eye. So vitreous is in contact with the internal limiting membrane of retina. So in PVD what happens, that there is separation of the vitreous from the internal limiting membrane of retina. So third cause is PVD. Fourth cause is rhegmatogenous RD. Fifth cause is neovascularization following retinal vein occlusions. Neovascularization following retinal vein occlusion can lead to vitreous hemorrhage. And the last cause and the important one you should keep in mind is trauma. Trauma is the most common cause. Just remember, the most common cause of vitreous hemorrhage in children is trauma, whereas in adults it is proliferative diabetic retinopathy. So most common cause of vitreous hemorrhage in children is trauma. So what else you should know in vitreous hemorrhage is the mechanism of vitreous hemorrhage, how, from where the bleeding is coming. So write down the mechanism. So there is bleeding from rupture, bleeding due to rupture of abnormal blood vessels. So from where these abnormal blood vessels are coming, these are seen due to neovascularization. Of retina. Neovascularization of retina, as you all know, is seen in which conditions? First one is diabetic retinopathy. It is seen in diabetic retinopathy. Second, it is also seen in neovascularization, retinal vein occlusions, right. Then it is also seen in sickle cell sickle cell retinopathies and other ischemic disorders, other ischemic vascular disorders. These are the causes of neovascularization of retina, due to which vitreous hemorrhage is seen. Second mechanism is due to rupture of vitreous hemorrhage can occur due to rupture of abnormal retinal vessels, due to rupture of normal retinal vessels, they are seen due to rupture of normal retinal vessels. So, the rupture of normal retinal vessels, what are the causes? First cause is, again it is seen in posterior vitreous detachment. Second cause is retinal tear, and third cause is retinal detachment. So, these are the basic and the most common causes of vitreous hemorrhage you should keep in mind, and you should keep in mind that the most common cause of vitreous hemorrhage in adults is proliferative diabetic retinopathy, whereas the most common cause of vitreous hemorrhage in children is trauma. So, let us discuss next question. Coming to next question, association with the following appearance include all except. So, as you can see the image, this is an image based question. You can appreciate there is whorl like deposits, right, inferior part of the cornea you can see there is whorl like deposits. So, question number 243, the best answer possible here is option number A, past history of breast carcinoma is the answer. So, let us discuss what is the condition this is called. This condition is known as vortex keratopathy. So, let us discuss vortex keratopathy in detail. Vortex keratopathy. So, vortex keratopathy is also known as, you should know the other name of vortex keratopathy, it is also known as corneal verticillata. Corneal verticillata, right. So, what happens that there is occurs, what happens in vortex keratopathy is that there is whorl like pattern of golden brown or greyish like deposits are seen in the inferior part of the interpalpebral portion of cornea, inferior region of cornea there is whorl like deposits. From where this deposit is seen, write down, there is whorl like deposits. Whorl like pattern of golden brown or grey color deposits. Grey deposits are seen in the inferior interpalpebral part of the cornea, right. Why? Because certain medications, number of medications are associated with vortex keratopathy. A number of medications are associated with vortex keratopathy. So, what happens? These medications, these have affinity for cellular deposits present in basal epithelial layer of cornea, right. Why? Why they have affinity? Because of the cationic and amphiphilic properties of these drugs. So, write down, these drugs have affinity, or they deposits, they have affinity for cellular deposits, cellular lipids deposits. Cellular lipid deposits are seen in epithelial basal layer of cornea, right, because of cationic and amphiphilic properties. So this is the basic mechanism what happens in vortex keratopathy. Now what you should keep in mind is the name of the drugs which are associated with this keratopathy. So if the question is asked which is the most common drug associated is amiodarone. So guys, amiodarone, as you know, it is an anti-arrhythmic drug. It is an anti-arrhythmic drug. It is the most common cause of vortex keratopathy, followed by second cause. Second cause is chloroquine, hydroxychloroquine. Other is hydroxychloroquine, right? And the other cause, fourth one is the long-term use of tamoxifen. So it is associated with long-term use of tamoxifen also. Tamoxifen, it is used in breast carcinoma. It is used in breast carcinoma. So it is used in breast carcinoma. So the best answer is tamoxifen, because tamoxifen use is associated with vortex keratopathy, but it is not only drug which is used in breast carcinoma. There are other drugs also. So tamoxifen. So other drugs which are associated is the chlorpromazine. Write down chlorpromazine. This is used in schizophrenia and Fabry's disease. Fabry's disease. So Fabry's disease, you should keep in mind, this is important. It is important cause of vortex keratopathy. So there is renal failure in Fabry's disease. Renal failure is associated with high serum level of creatinine. In Fabry's disease, there is high serum level of creatinine is seen after renal failure, right? Now other cause is osteoarthritis. Which drug is used in osteoarthritis? Drug associated is Brufen. So these are the drugs, out of which most important one is the long-term use of tamoxifen. The most common drug which is associated with vortex keratopathy is, as we have discussed, it is amiodarone, which is an anti-arrhythmic drug, followed by chloroquine and hydroxychloroquine. So this is all about vortex keratopathy, you should keep in mind. Now coming to next question. Question number 244. They have asked you that surface ectoderm gives rise to all of the following structures except, answer here is option number D, anterior layers of iris. So as we have, you all know that option number 1 is lens, corneal epithelium and conjunctival epithelium, all the three structures they develop from surface ectoderm. So lens, the lens, epithelium of cornea and epithelium of conjunctiva all develop from surface ectoderm, right. So usually what happens is that the epithelium and the epithelium of all the structures, the epithelium develops from surface ectoderm, whereas the muscles develop from mesoderm. But in this case iris has unique feature, iris epithelium and iris muscles. Which muscles? You all know the muscles of iris are the sphincter pupillae and the dilator pupillae. The muscles as well as the epithelium of the iris, they develop from neuroectoderm. So write down, this is a unique feature. Unique feature of iris is that iris epithelium as well as the muscles of iris, which are the muscles of iris? Sphincter pupillae and the dilator pupillae. Both these muscles and epithelium, they develop from neuroectoderm. This is a unique feature of iris, important one. Right. Now let's discuss next question. Question number 245, they have asked most common causative agent of acute hemorrhagic conjunctivitis is. Correct answer is option number D, enterovirus type 70. So let's discuss briefly about acute hemorrhagic conjunctivitis. Acute hemorrhagic conjunctivitis. So there are two broad categories of the causative agents of acute hemorrhagic conjunctivitis. What are these categories? The viral causes and the bacterial causes. Viral and the bacterial causes. What are the viral causes we should know? First, the most important one is enterovirus. Enterovirus type 70. Second type is Coxsackie virus A24 and the last is adenovirus. Third viral cause is adenovirus. Now coming to the bacterial causes, is first is the pneumococcus. This is pneumococcus, write down. Pneumococcus and Haemophilus. These are the two bacterial causes of acute hemorrhagic conjunctivitis. So let's discuss briefly what is hemorrhagic conjunctivitis. It is also known as, the other name of acute hemorrhagic conjunctivitis is Apollo conjunctivitis. It is also known as Apollo conjunctivitis. So let's discuss the clinical features. Acute hemorrhagic conjunctivitis, the patient will have all the features of conjunctivitis. What are the features? Patient will have red eye, conjunctival congestion will be there, patient will have complaint of discharge, patient will have photophobia, blepharospasm. So apart from all the features of conjunctivitis, patient will have additional subconjunctival hemorrhage. So clinical features, all features of conjunctivitis plus there is subconj hemorrhage in acute hemorrhagic conjunctivitis. Now what else you should know in acute hemorrhagic conjunctivitis? The causes. Apart from this cause, what are the other causes? First write down is the trauma, second cause is hypertension, third cause is bleeding diastasis, bleeding disorders, third cause is bleeding diastasis and the fourth cause is pertussis or whooping cough. So this is all about subconjunctival hemorrhage. You should know the most common viral cause is enterovirus type 70. So let's discuss other question. Question number 246. Fincham test is done to differentiate between, the correct option is option number 1, A option, acute congestive glaucoma and cataract. So let's discuss Fincham test briefly. Fincham test. So what we do in Fincham test, it is used to differentiate between the colored halos seen in acute congestive glaucoma and immature cataract. It is used to differentiate between colored halos in acute congestive glaucoma and immature senile cataract. What other condition in which colored halos is seen is, third condition is acute conjunctivitis. Acute conjunctivitis, because of presence of discharge, patient will have colored halos. So you all know what is colored halos. Colored halos is nothing but it is multiple colored circles patient sees around the light source. These are colored halos. So how you differentiate between all the three conditions, acute conjunctivitis, acute congestive glaucoma, and the third is immature senile cataract. So what we do in acute conjunctivitis, because of discharge, if you irrigate the eye, or if you wash the eye, discharge will get over, right? Discharge will be absent and the colored halos will be absent. Colored halos absent if you irrigate the eye, right? Now we have to differentiate between colored halos seen in acute congestive glaucoma and due to immature senile cataract. So to differentiate we use Fincham test. What we do in this test, we use a stenopic slit. Stenopic slit is used, right? Stenopic slit is used. How it looks like? It looks like somewhat this, right? So this slit is passed in front of eyes. Now suppose my right eye is having acute congestive glaucoma and my left eye is having immature senile cataract. So what we do in Fincham test is that I pass this stenopic slit in front of my right eye. If my right eye has acute congestive glaucoma and I pass this slit in front of it, the colored halos will be intact, whereas if I pass this stenopic slit in front of my left eye having immature cataract, they will disappear, the colored halos will be broken. So this is how we do Fincham test. So this slit is passed in acute congestive glaucoma, the halos are intact, whereas if they are passed in immature senile cataract, the colored halos are broken. The colored halos are broken if we pass through immature senile cataract. This is all about Fincham test, used to differentiate between halos seen in acute congestive glaucoma and immature senile cataract. Now coming to next question. Question number 247. Periphery of retina is best visualized with which of the following technique? The correct answer is option number A, indirect ophthalmoscopy, right? So let's discuss indirect ophthalmoscopy briefly. Indirect ophthalmoscopy. So indirect ophthalmoscopy is used for examination of the periphery of the fundus, right? Write down. It is used for examining fundus, periphery of the fundus. So let's discuss question number 247. The periphery of the retina is best visualized with which of the following? Correct answer here is option number A, indirect ophthalmoscopy. So let's discuss indirect ophthalmoscopy in detail. Indirect ophthalmoscopy. So in this technique it is used for examination of the fundus or the posterior segment of the eye. So first of all you should keep in mind what is the fundus, what constitutes fundus. Fundus, it is a view of transparent retina. It is a view of transparent retina, right? What else? Transparent retina and transparent vitreous and choroidal vessels, choroid, right? So these constitutes fundus. Remember the red glow of the eyes is due to choroidal vessels. So by indirect ophthalmoscopy we can examine the fundus of the patient, right? So let's discuss briefly about the differences in direct ophthalmoscopy and indirect ophthalmoscopy. What are the differences in direct ophthalmoscopy and indirect ophthalmoscopy? In direct, what type of image is produced? What type of image is seen? It is virtual and erect. Virtual and erect image is formed in direct ophthalmoscopy, whereas in indirect ophthalmoscopy there is real and inverted image. Real and inverted image is formed on indirect ophthalmoscopy, right? It uses a +20 diopter condensing lens is used in indirect ophthalmoscopy, whereas no lens is used in direct ophthalmoscopy. Now coming to magnification. The image produced in direct ophthalmoscopy is 15 times magnified, whereas in indirect ophthalmoscopy it is 3 to 5 times magnified. 3 to 5 times magnified on indirect ophthalmoscopy, right? Now let's discuss the area visualized on direct. Area visualized. The area visualized by direct ophthalmoscopy is mainly the central fundus, which constitutes optic disc plus macula. No view of peripheral fundus is seen in direct ophthalmoscopy. Whereas in indirect ophthalmoscopy, you can visualize, apart from central fundus, you can visualize periphery of the fundus. So apart from central fundus, you can also visualize periphery of fundus. Periphery of retina can be visualized up to ora serrata. You can also see ora serrata, right? Now let's discuss the area visualized, or the field of vision, right? So in direct ophthalmoscopy it will gives you a 2 disc diameter view, 2 disc diameters, whereas in indirect ophthalmoscopy it will give you a wider view of 8 disc diameters, right? It will give you around 45 degrees of field. 45 degrees of field vision is there in indirect ophthalmoscopy, whereas in direct it is around 10 degrees, right? So these are the basic differences. Now what are the advantages of indirect ophthalmoscopy? Advantage is that it will give you stereopsis. What is stereopsis? Stereopsis is binocular depth effect. Binocular depth perception is there. Binocular depth perception is there in indirect ophthalmoscopy, which is absent in direct ophthalmoscopy, right? So it is absent in direct ophthalmoscopy. And fundus can be visualized. Fundus can be visualized in hazy media. Hazy media in indirect ophthalmoscopy. Why hazy media? What constitute hazy media? Like conditions like corneal opacity and cataract. So in such conditions, fundus can be visualized by indirect ophthalmoscopy, whereas it is difficult or not possible in direct ophthalmoscopy, right? So these are the basic differences you should know about direct ophthalmoscopy and indirect ophthalmoscopy. Now coming to other options they have given. What are the other options? Ultrasonography. What is ultrasonography? Ultrasonography is B-scan ultrasonography. B stands for brightness, right? What is B-scan ultrasonography? So B stands for brightness, and it uses 7.5 to 10 megahertz sound waves. So sound waves are used in B-scan ultrasonography to visualize the fundus in opacified ocular media. So fundus is examined in opacified media. By opacified media, we mean that the ocular media is not clear because of it can maybe due to dense cataract. So in such conditions where media is not clear, fundus cannot be visualized from direct or indirect ophthalmoscopy, we will use B-scan ultrasonography, right? Whereas retinoscopy they have given in other option, it is a test we do for refractive error evaluation. Now coming to next question. This is again an image-based question, question number 248. What is the diagnosis? They are asking what is the diagnosis. Correct answer is option number A, Epicanthus. This is Epicanthus. So as you can appreciate in this image, there is semilunar fold of skin. You can appreciate over the medial side of the eye, right? Over the medial canthus, you can appreciate a semilunar fold of skin. So let's discuss briefly about Epicanthus. So Epicanthus is a semilunar fold of skin over the medial canthus, right? Medial canthus of eye. It obscures the view of caruncle and semilunar plica semilunaris, right? So it obscures the view of caruncle, right? Important point to note here is in Epicanthus is that it is the most common congenital condition. It is most common congenital lid condition. Most common congenital lid condition, right? Now it can be unilateral or it can be bilateral, but mostly it is bilateral. Mostly it is bilateral condition, right? Mostly it is seen in upper lids, right? Now it can be associated, this is important, it can be associated with congenital ptosis, or it can also be associated with Down syndrome, right? Now what will the clinical presentation of the patient? Patient with epicanthus will present to you with pseudostrabismus. Patient presents with pseudostrabismus or pseudoesotropia. Patient can present with pseudoesotropia, right? Patient seems to have inward deviation of eye, which is known as pseudoesotropia, right? How you will differentiate or confirm this condition? You will perform a cover and cross cover test, which will give you a condition of orthophoria, which is normal alignment of the eye, right? So this is all about epicanthus you should know. Coming to the last question, question number 249. Again, this is an image-based question, and they are asking procedure shown in photograph is done by using, correct option is gold chloride. Option number A is correct, gold chloride. So what they are doing in this picture, this procedure is known as tattooing. This is corneal tattooing. Tattooing of the cornea is done. Now what are the indications of corneal tattooing? Write down. It is mainly done for altering the appearance of the eye cosmetically. Mainly done for alteration in appearance of eye, cosmetically, right? Which is the leading cause of corneal tattooing, which is the most common cause in which we do corneal tattooing? That is the corneal opacity. So write down the causes. Which are the conditions we do corneal tattooing? Leading cause is corneal opacity. Corneal opacity due to glaucoma, due to cataract, due to keratitis, right? These are the causes of corneal tattooing, and it is the most leading cause. What are the other causes? In some conditions, corneal tattooing is also done to improve the eyesight of the patients. What are those conditions? Write down. Those conditions are albinism, aniridia, iridodialysis, and keratoconus, also done in keratoconus. Now there are some conditions in which patient is having a symptomatic glare. So to remove this or to get rid of this symptomatic glare problem, we do corneal tattooing, right? So what are these conditions? These conditions are seen in large iridectomies, or there can be a traumatic iris trauma, right? So these are the conditions in which we perform corneal tattooing. Which is the dye which is used? Write down. The dye used for corneal tattooing Indian ink dye is the most common one. So Indian ink is the most common dye used. What are the other methods? We can perform corneal tattooing by chemical dyeing also. Chemical dyeing. Chemical dyes are used. Which dyes? Gold chloride, which is the answer in this question, gold chloride, or we can use platinum chloride. So these are the other methods of performing this procedure, right? So this is the ophthalmology part of this grand test. Best of luck. Thank you.